All right, welcome back. I hope you had a good lunch and are staying relatively warm. Anyone take a chance to go outside and see what their snow, ice fall looks like? It's wild out there where you are. You're in Southeast. Is that what you said, Dylan? Yeah. Okay. Wow. I was looking at the news. It looked like Portland definitely is getting some weather. That's for sure.
Babe, can you bring more water? Oh, sorry, everyone.
Hey, Alexis. Awesome. Well, I know in Eugene where my family is, they just have like a sheet of ice, really. Not a lot of snow, but definitely a lot of ice. We have probably about 2 inches here where I'm at, so not too crazy, but the roads have other places have more. Then the gorge, my response from my dad was lots of snow, it's windy. So I don't know what that means, but there you go. Good old dads. All right. We're going to get back into it. We're going to go through our neuroanatomy and central nervous system review. I think we'll be able to make it all the way through this. We may end up taking our break at the hour prior to finishing this one completely, and then we'll move into the gastrointestinal system. Those are a little bit shorter, and we'll wrap up our day with embryology. Oh, what did I just do? Let me not do that. All right. I'm going to small your faces, so if you have questions, feel free to call it out. So here's all the bones of the skull. Know them all, right? Well, we're going to talk about some areas that we want to care about in regards to bones of the skull more than others. First things first, we talk a moment about our fontanelles. Our fontanelles' function is to allow for passage of the head through the birth canal, accommodate the growth of the brain and the cranial bones as they do not articulate in the newborn. These soft spots or fontanelles are membrane-covered parts of the skull, and it's where our eventual adult sutures, as we can see, coronal lambdoidal sutures, will form. If there's a bulge or a tense fontanelle, that could indicate increased intracranial pressure. So again, do you need to know all of them necessarily? No. I would more pay attention to the fact that this intramembranous space are going to eventually form our adult sutures that we know, which are those contact points between the bones of our skull. The anterior fontanelle closes between 9 to 18 months, and then the sagittal suture between 1 to 2 months, but even could be closed at birth. Those are the two that tend to be asked about the most. So there's 22 bones in the skull and 7 associated bones, hyoid and ear ossicles. The neurocranium makes up kind of the bones we think about when we think of the skull, our frontal, parietal, occipital, et cetera, et cetera. The visceral cranium actually is derived from our pharyngeal arches. So when we look at our developing fetus, we're actually going to find that this portion of bones comes from a different background or base embryologically than this portion of bones. So we'll look at what that means when we get into our embryology section. When I mentioned pharyngeal arch, I want you to think of really it's a lot of our facial bone structures, right? Our mandible, our maxilla, our zygomatic bone. The most important bony structures in the skull come from our cranial base, and we have 3 cranial fossa: anterior, middle, and posterior. The anterior fossa is made up of the frontal bone, the crystal galli, and the cribriform plate of the ethmoid bone, and the lesser wings of the sphenoid bone that we can kind of see here. The important structures it contains is cranial nerve 1, our olfactory nerve, which kind of lies in this space here and contacts that plate, communicating with our nose for smell, and then obviously our frontal lobe. Our middle cranial base, or our middle fossa, is, I would arguably say, the most important fossa, and it's also asked about on NPLEX probably the most. So we'll have a separate slide even leaning into this more. But it includes the sella turcica to the greater wing of the sphenoid to the petrous portion of the temporal bone. And then the posterior is made up of a portion of the temporal and the occipital bones and contains our occipital lobe, our cerebellum, and our brainstem. So if we look at the middle cranial fossa continued, it contains our sella turcica, chiasmatic groove, our optic canals, our superior orbital fissure, our foramen rotundum, our foramen ovale, our foramen spinosum, foramen lacerum, and cavernous sinus. And these structures provide space for pituitary, optic chiasm, optic nerve, internal carotid artery, and cranial nerves 3, 4, V1, or 3, 4, 5, 1, 5 branch 2, and 6. Ooh, a lot of important structures come here. Also, part of our temporal lobe brain mass rests in this fossa. So I find pictures like this to be really helpful. It talks about, okay, what is the foramen, like foramen spinosum, and where is it located? Middle cranial fossa, and what goes through it? Middle meningeal artery. If you had to look at one picture to work on for anatomy of the skull base, this is the picture I'd focus on. Understanding you're not going to have a picture on NPLEX, but it'll help you learn these structures. Cribriform plate, it's in that anterior cranial fossa, your olfactory nerve. Optic canal, your optic nerve, cranial nerve 2, and your ophthalmic artery are here. Superior orbital fissure, it's in the middle fossa. This is where you have your trigeminal nerve branch 1, the ophthalmic division, cranial nerve 3, cranial nerve 4, cranial nerve 6. So all your nerves that control movement of eyes, your EOMs, and your superior ophthalmic vein. On the other side, we have our foramen rotundum. This is in our middle cranial fossa. This is where our maxillary division of the trigeminal nerve runs through. Foramen ovale, this is in the middle base. Again, our trigeminal branch mandibular division, branch 3, runs through here. Carotid canal, obviously here we can see this with our internal carotid artery. Foramen spinosum, I mentioned already. Foramen lacerum, it's filled with cartilage in real life, actually. Internal acoustic meatus, this is our facial nerve and vestibulocochlear nerve, so cranial nerves 7 and 8. Jugular foramens, where our glossopharyngeal, our vagus, and our accessory nerve, as well as our internal jugular vein run. And then our hypoglossal canal is where we have our hypoglossal cranial nerve 12. And lastly, our foramen magnum, which has spinal cord and vertebral arteries. Wow, lots of structures. So if there's one picture, if I can emphasize this anymore, this is the picture I would really work on getting down, be able to label these different spaces and what they contain. It is going to help you immensely. This is again just an image showing the structures and trying to kind of capture the bones that they might be a part of. So again, ethmoid bone is creating the cristogali and cribriform plate. Cristogali here, cribriform plate here. Our sphenoid, we have our lesser and our greater wings here. And then kind of showing the whole kind of sphenoid bone in this pink color. Let's see. Our temporal bone has the squamous and petrous portion that I mentioned. Occipital bone's back here. Parietal bone we can't really see, but it's because it's cut off. And then our frontal bone up here also kind of cut off. The other, if we're going to talk about another really important structure of the cranial region, the bony orbit of the eye socket is important as well, just because there's 7 different bones articulate here. The frontal bone up top, our maxillary bone, which would be, where is our maxillary? Right here, kind of this portion is the maxillary bone. Our ethmoid, where we can see ethmoidal, or right here, ethmoidal foramina with the ethmoid bone. Our sphenoid, we have our lesser wing of sphenoid and our greater wing of sphenoid. So right here, our lacrimal bone, I don't know, yep, I do in white here, and our zygomatic bone, making up our cheekbone. Lastly, our palatine bone, I do have it down kind of at the, right, this tiny little itty bitty piece you can see. But all 7 of these bones make up the bony orbit or the orbit of the eye. So I think it's important that you at least know they're here. Now, should you know the order that they're in? I think it's more important just to know what bones make up the bony orbit. It'd be really easy to put in a bone that does not make up the bony orbit to try to say like which one of these does not make up the bony orbit of the eye. That would be a very easy question. I think of like maybe after a traumatic incident, like you have a severe head trauma, you get the raccoon eyes, they're concerned about a fracture affecting the vision or the eye socket. What bones could be involved or what bone is not involved. And I could see them giving you a list that includes not a bone that's not on this list. I mentioned the sutures. Again, our fibrous joints between the bones of the skull. Our coronal is between the frontal and the parietal. Our sagittal is between the two parietal bones. Our lambdoidal is between the parietal and occiput. Our squamosal is between the parietal and the temporal. So you kind of follow this along. And then our bregma is the junction of the coronal and the sagittal sutures. We can see that right here. Our lambda is the juncture between the lambdoidal and the sagittal sutures here. And then I don't know if I have a good picture. I do, a pterion. That's the junction of the frontal, parietal, temporal, and sphenoid bones right at the pterion. So that's a great question because if there was like trauma here, what 4 bones could be affected, right? All right. And again, these ligaments that are connecting the bones are the unossified sheets of mesenchyme from intramembranous ossification. And we'll look at that process in the process of embryology. For muscles of facial expression, these are all of them here, a lot of them, and then also on this picture as well. Obviously, name and location is great, but I would probably lean more into name and action. They're all innervated for the most part by cranial nerve 7, right? Being able to move our face in different areas. And there's 2 muscles that are unique, our sphincter muscles that are orbicularis oculi and oris. Oculi, of course, being around the mouth or the eye, and oris being around the mouth. All other muscles we could consider dilator muscles, I guess you could say, but these are our 2 sphincter muscles. Besides the muscles of facial expression, there are a kind of 2 big muscles of mastication and then a few other supporting actors. Temporalis and masseter are your main 2 muscles of mastication, but if you choose just one, choose the masseter. It does the primary work of chewing. Temporalis and masseter both do elevation, but they're of the mandible, but they're also opposites in either retraction or protraction. So temporalis is going to retract, the masseter is going to protract. And we also have the medial and lateral pterygoids. These can elevate the mandible and they can protrude. The lateral does really good side to side. All 5 of these are innervated, or 4 of these are innervated by trigeminal nerve, the cranial nerve 5. So facial movement muscles, facial nerve, cranial nerve 7, muscles of mastication, trigeminal nerve, facial nerve 5. Then our muscles of deglutition or speech are all of these hyoid or thyroid except for digastric. So I love that because digastric is the one that's different. All of the others we can track kind of where they're going. So we have our mylohyoid, right, attaching to the hyoid bone. We're going to have then also the sternohyoid, and then we're going to also have our, oh, where's my pointer? I lost it. There we go. The omohyoid. I don't know if I have it yet. It's cut away on this side. So the omohyoid. So again, it's going to be cut up here. And then our thyrohyoid attached to the thyroid cartilage and the hyoid bone. So those are our 1, 2, 3, 4 hyoid bone attachment muscles. We then have our sternothyroid, so going from the sternum to the thyroid gland. And we have our cricothyroid, where I'm trying to see if I have this one on this picture. I don't believe I do. Oh, bummer. Do I have it on any other picture? Okay, I will have to find a picture to post, but it's small. It's not that doesn't matter too much, but the cricothyroid as well. You might be able to see it here. I just don't think we have a label to it. So those would be your 7 muscles of deglutition, swallowing, and speech. When we look at these muscles, we can look at the different innervations and the different nerves that are supporting. So both the digastric anterior belly and the mylohyoid are innervated by our trigeminal nerve, versus our digastric posterior belly is innervated by the facial nerve. Then from there, the only other cranial nerve involved is we get the cricothyroid is innervated by the vagus nerve. And then our thyroid gets the hypoglossal nerve, but really it's the first cervical nerve. So they kind of have hypoglossal via to get to the first cervical. The rest, we can see sterno, omo, and sternothyroid are innervated by the ons cervicalis, so not a cranial nerve, a superficial nerve. Blood supply to the head is relatively easy. So we can see coming off, we have our facial artery, which you can actually assess pulse from. This is coming from our external carotid artery. It's traveling along the lower border of the mandible toward midline of face. So any vascularity issues here towards midline of face, anterior face, and kind of along the mandible, we could attest to the facial artery. The superior temporal artery coming up through our temporal region or temporalis muscle also comes from the external carotid artery, and it sends up and posterior to the mandible, but in front of the ear. These are your two major branches for the external carotid that are actually going to blood supply the face and those facial muscles. When we look at venous drainage, we can see the facial vein begins just under the bony orbit, and it's going to descend kind of obliquely towards our inferior down lateral border of the mandible. So let's find that facial vein here. Here's our facial vein, moving downward and then outward. Ultimately, it's going to head into our internal jugular vein for drainage. This vein will also communicate with our superior ophthalmic vein and will also, so where's our superior ophthalmic vein? We said our inferior ophthalmic vein. I might have cut it away in this picture, but it will communicate with the superior ophthalmic vein as well as the deeper cavernous sinus, because that's what the superior ophthalmic vein communicates to. And this is how we can kind of have these routes of infection from the face to the cranial dural sinus is via these drainage connection points, where in theory, bacteria or some type of virus could hijack those blood pathways and get into these external spaces. From a lymphatics view, anyone who does lymph massage or gua sha to their face may actually already feel pretty confident with these facial lymphatics. And obviously, we've done our lymph exam of the neck, so we are relatively familiar with some of these. But the lymphatics of face and neck follow our major blood vessels in the area, and they drain inferiorly toward the heart. Typically, we can't palpate them, but we can if they're infected or inflammatory. Oftentimes, not necessarily needing to know how to name them outside of what you've already learned for palpation. So thinking about fluid up to the head, the brain represents 2% of body weight and gets 15% of cardiac output, and it's responsible for 20% of oxygen consumption and glucose consumption. So the brain pretty much has a constant steady supply of blood and oxygen unless if something's really wrong, which on a side note is why the brain itself, through cerebral spinal fluid and chemoreceptors, does not actually assess for oxygen status. It's assessing for pH change in the form of hydrogen ions, indicating an elevation in CO2. Versus our peripheral circulation, we monitor for both CO2, pH, and oxygen. But the brain really just pays attention to pH change in CO2 because the oxygen state will rob Peter to pay Paul, for lack of a better phrase, to make sure our brain stays oxygenated. Venous drainage to help with decreasing increased intracranial pressure. It's really a series of valveless sinuses. So these like pools of blood that have collateral channels to communicate, because we're not really having to work against gravity here. We have to go just down via gravitational pull back to the heart via our superior vena cava eventually. So we really don't need to have these like valves and pressure channels. We are able to flow kind of towards gravity back to the heart. And then the CSF that is going to surround in the ventricles, as we'll see, allows our brain to float really nicely in the skull and allows for us to not feel the heaviness of our brain and structures. Going now a step under, so we were looking at the bones and the structures of the bones. So looking then right beneath that at the meninges, these are our connective tissue. So a different type of connective tissue proper, that encloses and protects our brain. And there's three portions. We have our dura mater, the arachnoid mater, and the pia mater. And let's see if we can find all three of them here on this picture. So you can see the dura, you can see the arachnoid, and then the pia, because it's so closely attached to the actual brain, it's covering the cerebral cortex, almost like the visceral flora does to the heart. You can't even really separate it. You have to tease it out from the cerebral cortex itself. So we can see kind of these different membranes, the dura mater, the arachnoid mater, and then pia. Dura is the tough mother. It is tough, it's fibrous, it surrounds the brain, has firm attachment points to the skull, and it's going to create our dural folds and our venous sinus system of the brain. So our venous drainage is affected by our dura mater. The arachnoid mater is more of a web. We can kind of see what it looks like here with our little guide. It's the middle layer. SCSF flows underneath this layer in the subarachnoid space between the arachnoid and pia mater. It also has the arachnoid villi, which helps with reabsorption of CSF, returning it to the bloodstream so that it has a constant cycle. And then pia is the soft mother. It's a very thin layer. It's adhering to the brain and the spinal cord. It is impermeable to fluid, and it covers every surface of the brain except for a few areas of the ventricular system. But for the most part, it's covering across the board. Moving then into how are these different areas separated, we have several different dural folds. One is the falx cerebri, which we can see here. That's located in our longitudinal fissure. It's going to separate our hemispheres of the cerebrum. And then our tentorium cerebelli is going to separate the cerebellum from the actual occipital lobe. And then our falx cerebelli, I don't know if I have it in this picture, I don't, separates our cerebral hemispheres and the posterior cranial fossa, and our sellar diaphragm covers the pituitary in its fossa. So when we see the pituitary, recognize that the sellar diaphragm is covering the pituitary as it sits in the fossa in the sella turcica. Moving down the spinal cord, remember, we have these connective tissue structures moving downward, but when we get to the end of the spinal cord, we have something called the denticulate ligaments, which are specialized structures of the pia. They're very thin, they are ligamentous, and they emerge from the pia of the spinal cord and attach it to the dura mater. They are thought to kind of help stabilize the spinal cord and kind of keep these layers together. And you can see, it's really hard to see this here, but essentially they're like attachment points, connective tissue attachment points. The filum terminale, that's this kind of structure moving down here, is the connective tissue cord that's continuous with the pia mater that extends from the lowest tip of the spinal cord, the conus medullaris, to anchor it at the base, at the level of the sacrum and the coccyx. So you could think of the filum terminale as like the end cord that's tying the spinal cord down so it can extend its length and doesn't move upward, versus denticulate ligaments are emerging from the pia, attaching it to the dura mater to stabilize spinal cord motion within its fibrous connective tissue sac. All right. So I mentioned before the ventricular system. I mentioned that when we were talking about kind of structures and drainage and things of that nature, the ventricular system of the brain refers to our ventricles, which are our spaces intracerebral within the brain that cerebral spinal fluid moves through. So we have two lateral ventricles. We can see these lateral ventricles here. Here's one, here's two. They're C-shaped. They come from the neural tube. So during our development, we'll see this neural tube that will form. And these ventricles, the lateral ventricles, are actually derived partially from that neural tube. The spaces kind of curve from the medial part of the hemisphere around the temporal lobes. And so they really do look like the structure of a C. And they're combined inside of them, they contain cerebral spinal fluid. Cerebral spinal fluid will move from our lateral ventricle into the third ventricle, and it does so via the interventricular foramen of Monro, technically, although nowadays we'll hear it often just referred to as the intraventricular foramen. From there, from the third ventricle, we're going to move down into it's between the halves of the thalamus and the hypothalamus, and we're going to move via the cerebral aqueduct. Let me see if I can show us here a good picture of our cerebral aqueduct. Maybe not. Where's the ventricles? Here's our little pituitary. Here's our fourth ventricle, our third ventricle. So cerebral aqueduct would be here. So moving from our third ventricle via the cerebral aqueduct to our fourth ventricle, which lies between our medulla oblongata and our cerebellum. And then from there and we can see again, moving between the third ventricle to the fourth via that cerebral aqueduct. From the fourth ventricle, CSF passes down into the spinal canal. So it could all go all the way down there and circle the spinal canal, or it'll exit here and actually move back into the subarachnoid space around kind of the brain surface. And it can be reabsorbed when it's in this kind of subarachnoid space place back into blood as needed. The foramina that it exits into the subarachnoid space is the foramina of Luschka and Magendie. You also could hear it referred to as your median aperture. This is probably the more common name associated nowadays. And then it's going to ascend superiorly, like I mentioned, all the way around, and it'll get reabsorbed into our sagittal sinus up top via these arachnoid granulations. And then from there, it'll be repurposed, reprocessed back into CSF, which will start in our lateral ventricles. And the process will continue. So if we go for the whole meal deal, we go CSF is produced by choroid process via blood, moves into the lateral ventricles. It's going to move via the interventricular foramen into the third ventricle. It'll move then via the cerebral aqueduct into the fourth ventricle, where it'll either move and surround our spinal cord. It will leave via the median aperture and go into the subarachnoid space, where it will then be reabsorbed via arachnoid granulations into our sagittal sinus, that venous blood system, which will flow back through and eventually will supply the needs, the nutrients to create more CSF via the choroid plexus. And this process just repeats and repeats and repeats. Arterial supply for the brain then. So how are we getting this blood supply? Well, starting from the aorta, we can see we have our brachiocephalic branch, our common carotid, and moving up from our common carotid here, we can see the common carotid is going all the way back up here, or we have our vertebral arteries coming off our right and our left. This would be, I guess, we're looking at the person, this would be the left common carotid versus the right vertebral artery versus the left. We see our circle of Willis, which we'll talk about here in a moment, and our other arteries down below. And then we are moving from these common carotids to our middle cerebral artery. So let's zoom in closer, shall we? Yes, we shall. So our internal carotid. Remember, I said our external carotid artery is going to supply blood to our face, right? Our facial artery, our temporalis artery, the ones that are moving directly superficial. That's going to be our external carotid artery. Our internal carotid artery is going to break off or branch off from the common carotid, which will come off either the arch of the aorta or brachiocephalic artery, depending on which side you are, right or left. The internal carotid will split from the external carotid at the carotid sinus. That's their split point. And I believe we can see the carotid sinus right here. Then the internal carotid artery splits into the anterior and middle cerebral arteries. So we can see moving up, we have our internal carotid here, and then we have our anterior cerebral and our middle cerebral arteries. We have this split off, and then we'll start talking about our communicating arteries there. But again, middle cerebral artery, anterior cerebral artery. So hard to see in the picture. That's why I wrote it out. The majority of the cerebral hemispheres, the actual brain themselves, are supplied by the internal carotid, which has split into the anterior and middle cerebral arteries. If we then look at the vertebral artery, so I'm going to move this down so we can see, the vertebral artery ascends from the subclavian artery. It's going to pass through our transverse foramina of vertebra C1 through 6. It does not pass through C7. It's going to move through the atlanto-occipital membrane and the dura. So we can kind of see this vertebral artery coming up through the vertebra. We can see it passing up through here, and we can see it moving into the actual brain. And we have our left and our right sides of the vertebral artery. So vertebral artery from subclavian. If we go back, we can see our internal carotids, the anterior and middle, from our anterior cerebral and middle cerebral from the internal carotid. So separate these out because they have a different source. So from our vertebral artery, we can talk about our basilar vertebral system, which supplies blood to the spinal cord, our brainstem, our inner ear, our cerebellum, our occipital, and our temporal lobes. Because we've already said that our anterior and middle cerebral arteries really supply the majority of the cerebral hemispheres. So we're saying, okay, this is supplying those other structures. So the vertebral arteries, as they come up through the transverse foramina, they're going to unite to form our basilar artery. You can see this big basilar artery here. These are our vertebral arteries that have come up via the transverse foramina, and they merge together into this beautiful basilar artery. The basilar artery is going to ascend on the ventral surface of our brainstem. And we'll see that we have lots of different branches from the basal artery, including our anterior, inferior cerebellar, our pontine, our superior cerebellar, and our posterior cerebral arteries. So we're going to need to look at how all these things kind of come about. And I believe, yeah, I have that picture here coming up. We also have spinal arteries. So we can see the vertebral artery will branch to anterior and posterior spinal arteries. And then we have radicular branches of intercostal arteries in the actual intercostal spaces. So those are separate. Those are arteries to actual spinal cord, the spinal segments, those regions. We're really going to focus on the vertebral to the basilar artery with this vertebral basilar system. So our circle of Willis, another great picture to learn how to draw yourself. This really is how we see all of the blood vessels in the brain communicate in a really small area. And it describes the communication branches from the anastomoses between the cerebral arteries. How are they talking? So let's start from, let's start from back here. So if we look back here, we see our vertebral arteries coming together to form our basilar artery here. Our basilar artery has some branch points. We can see branching off the basal artery almost immediately is this internal auditory artery. Then secondarily is the anterior inferior cerebellar artery, which makes sense to the cerebellum. We have our pontine arteries that are almost like lying on the surface of that brainstem. And then from here, we'll see our superior cerebellar artery to kind of mark the end of that basilar artery space. Once we get to this point, then we're going to start to have some communication with our cerebrum. What I mean by that is we have the input of our posterior cerebral artery coming in through here. So actually really communication, not just with the brainstem or structures below the brain, but with the brain itself. And then we also will start to see these communication arteries, starting with our posterior communicating artery, and then followed by, we'll see up front, the anterior communicating artery up here. So the anterior communicating artery, now we're kind of to this image here, connects our anterior cerebral arteries. Remember, our anterior cerebral arteries came from who? They came all the way from our internal carotid. So we've now connected all these pieces of the puzzle together. Our posterior communicating artery back here is going to connect our middle and our posterior cerebral arteries. So if we go back again, we had our internal carotid splitting into anterior and middle cerebral arteries. Our posterior cerebral artery comes off of our basilar artery, right? So in our circle of Willis, our posterior communicating connects that middle cerebral artery, which is here, to the posterior cerebral artery, which is here. So our posterior communicator or posterior communicating artery or section of the circle of Willis connects our internal carotid to our subclavian, right? Because our subclavian led up to our vertebral arteries, which eventually became the basal. So this is where those two systems connect in the base of the brain. Now, the middle cerebral artery will track along the lateral fissure and the lateral surface of the cerebral cortex. And we're following this middle cerebral artery here coming off of that circle of Willis. There are multiple different branches. The cortical branches are going to move to the lateral surface of the cortex. And if you had a stroke in the cortical branch of the middle cerebral artery, you could see paralysis and sensory loss on the opposite, the contralateral side. Damage to the dominant side typically results in aphasia, inability to speak. The lateral striate arteries move to the internal capsule and the basal ganglia, and you typically see a hemiplegic state if these are affected via stroke. And so if we're seeing, let me see if I can find these on the image. I don't know if I will be able to. I might not be able to see a beautiful version quickly here. I don't know if it really matters, to be honest, because we know where they go. Yeah. this is not super helpful. It's just all the specific names. But really what I would lean into is cortical branch is going to, because it's going to the cortex, if you have stroke there, you're going to have paralysis, sensory issues on the opposite side because of the flip-flop. If you affect the lateral striate arteries, again, from the middle cerebral, this is going to, because they go to the internal capsule, the basal ganglia, which are, you know, those important neuron structures or essentially neuron gatherings, hemiplegia is what you're going to be looking at. So that was middle cerebral. Moving to the anterior cerebral, again, supplied by our internal carotid. It's going to move along the medial surface of the cerebral cortex, including the cingulate gyrus, which is part of our limbic system. And you'll see if you have a stroke along this aspect or any of its branches, paralysis and sensory loss in contralateral leg and foot based off of where it is innervating or where it's providing blood supply to. And the posterior cerebral, it's going to your occipital and your temporal lobes. If you have an occlusion of this artery, you're thinking issues with vision, specifically our occipital area, facial blindness, so inability to recognize faces. And you could see contralateral deficits of facial, vagus, and hypoglossal cranial nerves, and ipsilateral same side deficits of your oculomotor nerve. So this is really your posterior cerebral artery, the structures that can be affected. Again, some good pieces to just kind of go through, learn this picture and these communication points, and then connect it with where do these branches actually provide blood supply to the brain. And so what would happen if there was a stroke here? Okay. When we look at venous drainage, I mentioned we don't have to do a lot of work here with our venous drainage passageways because it's a passive system. We're moving down gravitational pull. We'll see that blood from cerebral hemispheres in the brainstem will drain outwardly into surface veins, and then our cerebral veins will drain venous blood into our dural sinuses. If we look here, we can kind of see what this structure, this process looks like. Our dural sinuses are these compartments that occur within the dura mater, and there's spaces between these meningeal layers to allow for blood conveying and movement of blood. And this is just showing kind of this big superior sagittal sinus that's occurring. We can also see the arachnoid granulation. This is where CSF can get reabsorbed into our venous circulation. This is our pia, this is our arachnoid, this is the subarachnoid space, and then our dura mater on the outside. So between the dura mater, we can see these venous structures, these venous sinuses are collected. There are dural sinuses associated with the falx cerebri. The superior sagittal sinus is located where the falx attaches. So we can see that here to the interior of the frontal, parietal, and occipital bones. The inferior sagittal sinus is located on the actual free edge of the falx. So we have our superior sagittal sinus up here. And then down below, I'm seeing if I have an image of it. That's good. I don't know if I have a good image of the inferior, superior. Ah, here we go. Inferior sagittal sinus here at that base. I don't think I have it labeled here, but it would be at this base. Okay. The straight sinus connects the inferior sagittal sinus with the confluence along the intersection of the falx cerebri and the tentorium cerebelli. So kind of at this space here. There are some dural sinuses associated with our cranial base. Our cavernous sinus, probably our most infamous, the one we hear about the most, lies on either side of the body of the sphenoid bone of the sella turcica, essentially. So our cavernous sinus located here, and it would also locate here. It's just been cut away. This is where blood from local sinuses, orbital veins go. And so this is how we could spread infection from our sinuses or our eyes into the brain because of that communication point. It also is going to communicate with the pterygoid plexus in the lateral pterygoid muscle. So all of those regions, deep regions of the face. And then we have the inferior and superior petrosal sinuses, which drain blood from the cavernous sinus backwards into the transverse sinus. Our cavernous sinus, again, this is showing another image. This is giving us a picture of like optic chiasm here. It's showing our pituitary gland. It's showing our internal carotid artery, which is cut, our sphenoidal sinus, nasopharynx, and then how this cavernous sinus kind of interrelates and where these nerves would be our cranial nerves. So because the cavernous sinus surrounds the pituitary gland, we can see kind of really how intimately it interacts with the brain and the brain stem. And there's multiple different structures that are passing through this sinus from the interior of the neurocranium, through the dural layer, through the sinus, and then through the perosteal dural layer to exit. And so here's again those images of the internal carotid artery, cranial nerves, and any infection in the sinuses, it's so close. So if we had a really bad sinus infection that was left untreated and potentially spread through this space, it could get into the brain and cause a really significant meningitis. Looking at our spinal veins, we can see that we talked about spinal arteries kind of coming off of the vertebral arteries. Our spinal veins are called the anterior and posterior longitudinal sinuses. They're valveless veins. They're located around the dura, and blood can flow up or down the vertebral column. There's also the basovertebral brain, which drains the actual body, the vertebral body itself, and it is the connection point for prostate cancer into metastasis into the vertebra. The emissary brains is just showing that venous blood can flow freely between the scalp and the sinuses. So there are really those communication points there. This helps with thermoregulation. And so in like a state of being too hot, cooler blood from the surface travels internally to cool the brain, and vice versa. When we're cold, we can send more heated blood flow to that region to warm the brain or warm those regions. Love it. Yes, so that's a great tool. There's also a couple other videos too if you don't have a TikTok, so I'm happy to share it, but that's a great tool as well. Awesome. Thank you. Looking at our central nervous system and our brainstem, we can see midbrain, pons, and medulla oblongata, and these are really, really, really important structures of the brain, probably the most important structures of the brain, just because there's so much stuff that happens from them. So our midbrain, we have cerebral peduncles that are the connecting tracts from the pons to the cerebrum. This is how these sections are communicating. Remember, a tract, when it's in the brain, think of it as a nerve in the peripheral system, right? So tract is like a collection of axons that is in our central nervous system, versus a nerve is a collection of axons in our peripheral nervous system. The substantia nigra is also an important component in the midbrain. It's dopamine producing, associated with reward, addiction, movement. So this is the area that gets damaged in conditions like Parkinson's disease. This is also an area that's common for a brain bleed. So if there was a hemorrhagic stroke or something of that nature, and there's a bleed in the substantia nigra, you could see issues with dopamine production. So problems with movement, reward, and addiction, and you could see a mood change if this area is affected. There's mass, corpora quadrigemina, I would say less important. This is just the masses that make up the superior and inferior colliculi. More important to know these tracts and the substantia nigra, and the nuclei, collection of neurons for cranial nerves 3, 4, and 5. The sensory portion occur in the midbrain. The cerebral aqueduct also will pass through this section, allowing for CSF drainage from that 3rd to 4th ventricle. So if you had to know anything, I would memorize, this is the communication tract from our cerebrum to the spinal cord. This is your dopamine production. These are your nuclei, or so your neuron cell bodies for these nerves, and the cerebral aqueduct passes through this region. Our pons is inferior to our midbrain, so we're kind of moving down here to the pons, this little circular shape. It means bridge. It has connecting fiber tracts to connect the medulla and the cerebellum with upper portions of the brain. So again, it has that collection of axons to connect these pieces within the CNS. It also contains 2 important respiratory centers that work with the respiratory centers in the medulla, and that's the pneumotaxic and apnoistic respiration centers. The pneumotaxic respiration center in the pons actually is sending inhibitory signals down to the medulla, and this allows for an increased rate of breathing. And I'll talk about why that makes sense more when we look at respiratory physiology here at the end of our 4 weeks together. The apnoistic center is almost like the e-brake of breathing that when pulled or stimulated could cease and cause an apneic event to occur. In the pons, we also see nuclei for cranial nerve 5, 6, 7 and part of cranial nerve 8. Again, it's the motor portion of cranial nerve 5, which is the trigeminal nerve. So think of their areas of muscles of mastication. And lastly, our medulla oblongata. This is where a lot of our autonomic nervous system function happens. We have our two respiratory centers, the DRG and the VRG, the dorsal respiratory group and the ventral respiratory group. The dorsal respiratory group is by far the main trigger that is what's signaling normal inspiration. And then the ventral respiratory group is doing a lot of the essentially extra work of breathing. It's stimulating our accessory muscles. Our cardiac center is also located here, as well as our vasomotor center and reflex centers for vomit, swallowing, coughing, sneezing. So a huge amount of autonomic nervous system functions happen from this portion of the brainstem. It also forms part of the fourth ventricle and contains our corticospinal tracts, which we call pyramids, as well as the decussation of the pyramids where the motor fibers cross. So if there's an issue with crossing of these fibers, moving the left fiber crosses to the right and vice versa, look at the medulla oblongata as being like the cause or the issue, the reason that this is maybe not working appropriately. These are your nuclei you'll find here, cranial nerves 9, 10, the vagus nerve, hence the like major autonomic function. 11 and 12, all are coming off that medulla oblongata region. Okay. A few other central nervous system structures before we kind of pause and stop. Looking at the spinal cord, the white matter, this also could apply to the brain, is myelinated and it's the outer portion of the spinal cord versus the gray matter is unmyelinated and it's the inner H portion of the spinal cord. You also can associate the gray matter with more neuron cell bodies and the white matter with more axons or tracts than cell bodies. It's not 100% true, but it's a general assumption that you could make. The central canal is filled with cerebral spinal fluid and it runs longitudinally along the length of the spinal cord. It's continuous with the ventricular system of the brain, which again, those ventricles. The dorsal horns, I don't know if I have a better picture here, but the dorsal horns are sensory nerve tracts. The ventral horns are traditionally motor neurons. And we'll come back. I have another picture of the spinal cord that we'll look at. The cerebellum is with our position of us in the world in space. So it's balance, posture, learning motions, cognitive function, motor coordination. It will not initiate motion. That's our cerebrum, but it's responsible for fine-tuning movements. And damage to the cerebellum leads to loss of coordination. It can lead to loss of gait and loss of speech. You can kind of see where this is fitting into the larger structure of the brain as a whole. Now our cerebrum, I mentioned our cerebrum. I want you to think of this as the actual meat of the brain. It contains lots of different hemispheres that are, or really actually two hemispheres connected by corpus callosum, and lots of different sulci and lots of different gyri. We can see these gyri kind of here have certain names, and then these sulci have certain names, and we'll see why. But there are 4 lobes of the brain or the cerebrum to know about: our frontal, our parietal, our occipital, and then our temporal lobe. If we look at our cerebral hemispheres, the right and the left, they include the cerebral cortex and the basal ganglia included. Basal ganglia, again, referring to a collection of neuron cell bodies. The cerebral cortex is the superficial, probably like, I think 0.2 to 0.4 millimeters on top of these hemispheres. That's the site for the sensory motor integration and the perceptive qualities of our experiences. And so, power flash. And so we'll see kind of how these relate together here in a moment. We talk about our premotor cortex and postmotor cortex and all those things. The gyrus is just the convolution of the cortex. The sulcus are the fissures or the gaps between the gyri. And we can see that there's essentially 4 different fissures here: longitudinal, lateral, and central sulcus. In regards to the lobes of the brain, the frontal is involved with primary motor activity, behavior, and speech production. Our parietal is our somatosensory and proprioception lobe. This is where we are going to associate our somatosensory components, our vision, our audition, our formation of our egocentric space, and our sense of self. Occipital, just think vision. And temporal is our listening, our smelling, and memory. So a moment for the homunculus, it means little human, and you can kind of see both of them here. And it refers to the image of the body that's imprinted on the brain. So this is a brain. It's like we slice straight into it, and we're looking here at two different homunculi. There are two types. There's a sensory homunculus and a motor homunculus. The sensory homunculus is represented on the post-central gyrus, so this pink portion here, versus the motor homunculus is represented on the pre-central gyrus. So depending on which area of the cortex is stimulated, we can see what portion of the body will be activated or lit up, right? Sent a signal, a communication pattern. And then if it's on the precentral gyrus, it's going to be associated with movement, the motor actions, or it's on the postcentral gyrus that is helping us integrate our sensory components like pain, temp, soft sensation, sounds, vision, all of those pieces. So much more I would want to say about this, but for NPLEX, this will do for now. But there's so much more there from like a physiologic standpoint. A couple other structures, and then we'll break. We have our thalamus. All sensory stimuli, period, except for olfactory, are received by the thalamus. They are then integrated and relayed through thalamocortical radiations to specific cortical areas on the brain for integration. And there's two lobes, the right and left thalamus. These are showing all the different nuclei. While all of these nuclei are important, and sure, you can memorize them, I probably wouldn't. I'd focus on the larger areas like substantia nigra and some of these other components of brainstem, and then the corticospinal tracts potentially over these individual nuclei, although they could be tested on. It's just too much to memorize for one exam. The hypothalamus will comprise the walls of the third and fourth ventricle, and it's our integration region for our autonomic nervous system. So it's going to help us regulate water balance, body temp, thirst, blood pressure, those pieces. It also produces antidiuretic hormone and oxytocin, our posterior pituitary gland hormones that are produced by the hypothalamus and stored in the posterior pituitary. Now our cranial nerves, these are all of them here showing where they come off of, who they are, and what they do. I do have a breakdown. I just have a couple highlights I want to go through. Our olfactory, which is cranial nerve 1, we can see the olfactory bulb here and the fibers of the nerves really leaning right on that cribiform plate that we are looking at of the ethmoid bone and what we call the olfactory tract that moves back to the brain. This is our sense of smell. Our optic nerve is our sense of sight, which is going to transmit images back to the occipital lobe of the brain. And so if we look at that pathway, we can see that light that hits the retina. It's going to be transmitted via nerve impulses by our rods and cones, and they're going to travel through the optic nerve, which is located here. And they're going to get to this optic chiasm here. From the optic chiasm, the sensation, the signals will travel to the lateral geniculate body of the thalamus. From there, when they're at that lateral geniculate body on the right or the left side, the signals then will travel through optic radiations to the primary visual cortex of the occipital lobes. And we can see this crossover pattern here, right? So on the, I guess you could say the left side here of both eyes, right? So the lateral portion of the left eye and the medial portion of the right eye, those tracts are going to be sent over to the optic chiasm. The lateral portion of the left eye stays on the same side. The medial portion of the right eye crosses over here, and then they innervate back all the way at the occipital lobe. Same goes for the medial portion of the left eye and the lateral portion of the right eye. So we can follow these tracks and see that the optic chiasm is where the crossover occurs. So if there's an issue with like these crossover fibers, optic chiasm is a spot to look at for what would be affected. A few other cranial nerves, EOMs, they love to test you on them. Extraocular movements, you have your ocular motor, your trochlear, and your abducens. Your oculomotor innervates your superior rectus, your inferior rectus, your medial rectus, and your inferior oblique muscles. It also is going to innervate the levator palpebrae of the eyelid and the muscles that control constriction. So cranial nerve 3 does a lot, and pupillary constriction is one of the main things that it does that makes it unique. The trochlear nerve innervates our superior oblique muscle of our eye. So you can see that superior oblique here. And the cranial nerve 6, the abducens, innervates our lateral rectus of our eye, which I'm trying to see if I can see. I think it's cut away, but we can see it on this picture here, our lateral rectus of the eye. So abducens, lateral rectus, lateral gaze. Trochlear nerve, it's going to be down and out. So trochlear nerve, because it's innervating through superior oblique muscle, so down and out. And oculomotor nerve is really going to be the other, so it's going to be inward gaze typically. Trigeminal nerve has our three different sensory components, as well as a motor component. So it's sensory integration to the face and then the motor component to the muscles of mastication. There's 3 branches, the ophthalmic, which is V1, the maxillary V2, and the mandibular V3. The mandibular is going to provide our mastication muscle innervation. The facial nerve, cranial nerve 7, is going to go through our styloid mastoid foramen, and they'll have 5 divisions: a temporal division, a zygomatic, a buccal, a mandibular, and a cervical. And this is our motor innervation to the muscles of facial expression. This is more on our facial nerve, and then it's also showing a picture of our vestibular cochlear nerve, which I have on this picture. I don't. Cranial nerve 9 is our glossopharyngeal nerve. It's providing sensory innervation for the carotid bodies, the sinus. Carotid bodies and sinuses, remember, are sensing the pH changes and the chemical changes on the carotid arteries of the blood to increase or decrease respiration. So that's the kind of the autonomic portion of the glossopharyngeal nerve. It's also doing tongue, pharynx, middle ear movement and taste from the tongue. So it's doing both sensory and motor, which I have an acronym here for. Vagus nerve does everything. When in doubt, choose the vagus nerve. Accessory nerve we talked about for SCM and trapezius muscles. And then hypoglossal nerve is motor innervation to the tongue, except for the palatoglossus muscle. So you stick your tongue out side to side. These are all of them here. I have a super fun video that goes through a mnemonic. I'll post it if I remember. But on Old Olympus towering tops, the Finn and German dude some hops. That's like your classic for remembering the names of the cranial nerves. And I had another one for remembering if it was sensory, motor, or both, but that's also another good kind of component to learn. All right, you made it. Let me unshare so I can see your face, and then we can talk about what just happened to us with the central nervous system. All right. What big questions or pieces came up for you during that central nervous system throwdown, essentially?
I have a quick question. I know on the practice exam yesterday, I got confused on this. Could you just compare the corpus callosum to the falx cerebri? I for some reason I'm not sure where like they cross wires, and I think that they're similar. So just to separate them.
Absolutely. That's great. I have a picture that I think will help. So let me pull it up. I'm not sharing screens currently, am I? No, I stopped sharing. Okay. It's like, whoops. So if we look here, there are 2 completely different structures. I think we sometimes like confuse our brain about them, but let me get, because that was corpus callosum. Let me get a good picture of falx cerebri. And then falx cerebri, correct? Yeah, great. So think of falx cerebri as dura mater, so connective tissue descending downward, providing those separation pieces between these different sections of the brain lobes. Here we go. Okay. So sharing screen. I did a good old-fashioned Google search because it was faster than pulling up my slides. Okay, so falx cerebri, this connective tissue space separating out our hemispheres, right? Versus corpus callosum. If we look here at corpus callosum, it's specifically surrounding our actual septal region and our cingulate gyrus here. So corpus callosum is surrounding this region, kind of in the middle of the actual brain, versus falx cerebri is the connective tissue that's separating right and left hemispheres. The corpus callosum, we can see from an actual functional standpoint. I think this was the one I wanted. Yep, this one here. If we look at this, it's larger, it's white matter, not connective tissue. So I think that that's a kind of big piece here. It's connecting the two hemispheres of the brain versus this is separating via connective tissue the two hemispheres of the brain. So this would be like corpus callosum. This is the connection point. This is the falx cerebri, the separation point. That's kind of how I think of the two together.
That makes sense. Thank you.
Yeah, of course. It's a great clarification. That's a good one to ask about for sure.
I think that I'm also kind of confused on the differentiation between the falx cerebelli and the tentorium cerebelli.
Yeah, absolutely. Let's look at those too. So, okay, that picture had a good picture of the, so the falx cerebri, the tentorium cerebelli, and then the falx cerebelli, correct?
Yes.
Awesome. Yeah, good. Trying to see if I can get, okay, I think this is, yeah, this is the image I normally like to use because it separates them all three. Come on, computer. All right, here we go. Okay. So sorry about the image being a little small, but so falx cerebri separating our right and left hemispheres, tentorium cerebelli kind of at this base, and then falx cerebelli is separate. It's kind of the posterior portion of the tentorium cerebelli, and it's separating out the brain, like the occipital lobe, from the cerebellum. Versus the tentorium cerebelli, if we look at another image here of our tentorium cerebelli. No, I want images. Images. Let's see if I have another good image. It's not separating brain from cerebellum. It is separating out. Let's see if we have, there we go. This is what I was looking for. So it's, oh, this didn't show the, it is separating out. So falx cerebelli is separating, again, these two kind of components of the cerebellum versus tentorium cerebelli is separating out our occipital lobe from our cerebellum itself, if that makes more sense. I think this is a better view. This is cerebellum, falx cerebri, falx cerebelli, tentorium cerebelli. I think this one does the best job. This shows like brain above, cerebellum below, separation between the sides of the cerebellum, separation between the hemispheres of the brain. I think this one is the best image that we can see. So think of tentorium cerebelli as like your tent. It's sitting on it. It's like the roof of the cerebellum. And then the falx, both the falx are separating out right and left sides.
Thank you.
Yeah. This one's the best, I think. Great. Anything else that came up? Yeah.
I have one question. So when we are talking about anatomy, I guess if they say what part of brain is responsible for vomiting, like medulla is the answer, would that be considered anatomy or physiology?
It's kind of considered both.
Oh,
Sometimes
okay.
they'll consider it an anatomy question. If they asked you about the process of vomiting, the vomiting center and like what that process entails, that would be more physiology, but it's very flux, right? Like even sometimes a path question that's about an enzyme is biochemistry, right? So there is like some flux where it is kind of hard for us to know, would they put it in the category of biochem or the category of path? And that I don't have that answer because I don't write the test, unfortunately.
Okay, thank you. Yeah.
If I did, we would all pass easily, right? It'd be Because you
Yeah.
know exactly what's on it.
Yeah, thank
Dr.
you.
Dr. Pet Show,
Yes.
there's over 2,769 power outages.
Yes.
There was a fire here in the Cedar Mills, so hopefully we'll still have power because it seems like a lot of people are losing power.
Yeah, and I said that up top, that if you lose power, I'm recording all these sessions and I will post them to the Moodle page, and they'll be posted to YouTube as well. So you'll have access to them. If I lose power, I will cease to record for today and we will just stop wherever that is. We've gotten pretty far so far. But I will record the last whatever hours we have left and post them online. So if you're like, I want to conserve power just in case and want to turn off my stuff, that's fine. I will continue the last 2 hours of our time together, and I will post all of these recordings when I'm able to online. So you'll still have access even if you can't attend. Yeah, I've already had a lot of students lose power today. So and our lights have been flickering. So who knows? Good times. Stay warm. Okay, let's take a 10. We'll come back at 2:15. We'll go into the gut, and then we'll round out our time with embryology. So we'll do gut part 1, part 2 when we come back.